I'd like to welcome representatives from children. Elizabeth was here before, and this is Elizabeth Kantor, and you're the manager of the PICU
CHET program.
CHET program. And this is Judy Bergman, the trauma program nurse educator. So we'd asked them to come because the transfer process when we get pediatric patients and getting them to Rady's when appropriate, there's some questions, some confusion. So that's what they're here for. And thank you. Welcome for coming.
All right. Thank you. Good morning. I'm so happy to be back. Thank you so much for inviting children to return to your day of trauma. And this year I recruited Judy to come with me because she will help me speak more eloquently to the questions that I know that you have when your leadership reached out to us and asked us to join you again today. The question was, as Juana indicated, was related to the transfer process. And I had gone to Judy to say, please come with me and answer some of these more like logistical questions, because in terms of trauma, like you guys do trauma, and you do it excellent and you do it well. So we're gonna do it a little bit more informal this year. Last year I brought a presentation and this group was so engaged and interactive and had a lot of questions that it ended up being a really nice question and answer session. And I thought that maybe it might play out this way this time as well, which is why Judy and I just thought we would be here as your resources. We have a couple pieces of information to share with you. In the spirit of Halloween, I brought you some trick-or-treats. In here are some notepads that actually tie into the transfer process. There's some phone numbers on there that will be important to you. There are also reference cards in here that we as a hospital and a team pass out to our referring facilities. So it helps give you like a quick gauge of estimating weight, what you're expecting heart rates to be, what size tubes you would want. There's also phone numbers on here as well. So I will start this here with you. And there's some sticky pads in there. Before we get into this, I just want to ask, did anyone work yesterday? Was anyone involved in the active shooter drill that occurred yesterday? Okay, I was just asking, it was a San Diego Police Department initiative that Judy and I have been a part of for the past 4 or 5 months. And it has been beautifully scripted. The officer that's been in charge of it did a fantastic job of reaching out to a variety of facilities, and we knew that a patient was going to come to Children's. And I was just telling Judy that yesterday, nothing went as planned, and the entire day evolved in a completely different fashion. But I have to say, I think it was the better scenario, because truly, God forbid, if an active shooter occurrence happened, you are going to have multiple victims at multiple facilities, and having trouble pairing up parents with patients, or teachers with their loved ones and whatnot. So I had heard through the grapevine that you got victims here, which had not been the plan. So I was like, oh, we can talk about it tomorrow. But okay, I can fill you in on that on a different day. More what Judy and I wanted to make sure that we brought to you was that we at Rady's, on behalf of the trauma program and the CHET program, are a resource to you. And I know last year when I was here, there seemed to be some confusion just in terms of like, well, who do we call? Like, what's the first phone number? And really what I would like to say is use our CHET line. And that is on all of those documents, all 3 styles that I put in your little trick-or-treat bucket there. Use the CHET line, because even if it's not a patient that you think needs an emergency transport from your facility to ours, we, and I speak collaboratively on behalf of the trauma program, the ED, the CHET program, we can help your physicians and your team start connecting the right people, typically your trauma surgeons with our trauma surgeons. So that's probably like the biggest piece to take away from here, is to use us as your resource. In talking with Jonathan and preparing to come speak to you, I was asking about statistics, and it sounds like you get about 20 to 30 pediatric patients a year if we're on bypass or if it's a multi-casual event or whatnot, and 90% of those patients come to us. Now I recognize not all of them need the emergency transport that CHET tends to trigger, and it sounded like that maybe some of your questions were more in the realm of the stable patients that ultimately need to make their way to Children's. And that's more what I'm hoping Judy can help answer some of your questions. So do you have specific questions that you would like us to address?
I don't know if you can address this. Maybe this is something I haven't had too much opportunity to deal with you because when, but I was told very.
Why are you afraid? Are you afraid of me?
No, but one of our attending, no, you don't want that. One of our attending physicians was very upset because we had a very sick pediatric patient. This was a while ago, and somebody, I don't know who it was, one of the nurses or somebody else put out a call to the CHET team, and she was very adamant that it was only the physicians that called you guys. So that's, I don't know if that's something that is, that was a while ago, and eventually you guys were called and came and stuff like that, but she was kind of upset that.
Meaning your staff or our staff were upset?
Our attending physician that was on at that time was upset
I
because
see.
somebody
Okay.
else other than a physician had made the initial call.
Ah, I see. So I've had this scenario come up before when we've gone out to do outreach and join other facilities for days like this. And what I try to encourage people, and I think you all do it well, is like, hey doc, like let's call the CHET line. They can help us get this started. Because I do understand that the physicians like to be the ones that know that they initiated that call, and I think too they like to know, like, okay, I started the call, now the process behind the scenes can happen. I think as nurses, respiratory therapists, affiliate staff can say, like, give the nudge of like, hey, maybe this kid isn't going to go by CHET, but they can help us. So I can see where that would be my recommendation, is to streamline that and hand over the number and like, here it is, you want to give them a call and they can start taking care of the rest of it for you. I will say on a caveat to that, I think too, typically and ideally what we would like to happen is that if your physician called, and the way that some other arenas work is that if the physician calls, they immediately get connected to a physician, and I'm thinking that may be what was on her mind too. And in our system right now, we're not doing that. We're trying to take more of like an intake of the information, then triage and disseminate as we need to. We will absolutely connect with the physician if that's what needs to happen. So I'm wondering if that's, so help encourage people too, like it's okay to go ahead and call. It's really the intake of information and get the ball rolling.
Last year when you were here, this is what was agreed, and as we were talking is that the physician is the one, we give them the number, if they don't want it, we give them the number, they're the one to call so that it will make it happen quicker because you'll be attending to attending. That's what the information
yes.
she gave out.
And I agree with you. Our process behind the scenes changed a little bit. And my comment still here is have your physician make the first call. It is worth them to make the first call, but you might want to help manage their expectations that they're not going to get connected to a physician immediately, which is the way we were moving last year when I was here, and that has changed, so I'm sorry. But at least the expectation being that that first initial call is going to be an exchange of information and a request for what you want to happen.
Maybe can you just go over what happens when you call the line then, since things have changed? Because it's our understanding that it's a physician-to-physician acceptance of the transfer
Sure.
when you call that line.
So when you call the CHET line, your initial interaction is going to be passing on information. And you may just know a Jane Doe, you may not even know a name, but whatever information you have, and specify your request. Like, we're asking for a consult, we'd like to speak with the trauma surgeon, we don't think this is a CHET, but we know ultimately this patient is going to come here, and please connect us with the correct people. And that's what will happen on our end behind the scenes.
And then you get a return call from the appropriate physician.
So, correct, and so leave a phone number, a reliable phone number that you would like either the trauma surgeon, the emergency room physician, whoever to call back to.
So it's more like a transfer center person gathering data, then they put you in contact with the appropriate person.
Yes, I could see why you would look at it that way, yes.
They kind of triage the call to the appropriate people.
For instance, if it's a trauma patient, then the trauma surgeon will be the one that is contacted to call back to a specific physician and make it a trauma transfer. It would be very black and white. Like as soon as that kid comes through the door, we know it's a trauma activation, for instance.
And when those physicians talk, they may not activate CHET And I think that might be where some of the confusion comes in as well. Like, you're using our line as a consult line, and we're absolutely happy to do that, or you're using it as your logistical coordination line, and that's fine too. I think there's a feeling that like every call that goes into the CHET line is going to be a CHET, and we know that, you know, you have stable patients here that might not require an emergency transport team, but we can help you get that ball rolling. And so, like Judy said, like, the trauma surgeon would call back here, you decide that yes, this is going to be a trauma transfer. It's not going to happen via the CHET team, but when the child arrives to Children's, they know to expect this patient, and this is an incoming trauma.
But in general, how you want to transport the patient is typically up to the sending facility. So you can choose to use CHET. I mean, CHET's not opposed to it.
No, we're happy to come get any child you would like us to. Absolutely.
So you can reassure them that whatever mode of transport you would prefer, you can still connect physician to physician through that line. I think's bottom line.
So this is our best bet is to use the 858-277-3404.
Yes.
Because, you know, sometimes you guys are busy. We're also busy. And we're told there's a difference between the BLS transfer and a CHET transfer. And that's understandable. But to streamline it, what do we do in order to hit the best, you know, the best people at one time? Instead of making 2 phone calls, just make 1 phone call.
And that is what we'd like to try to streamline for you. So even if you know it's going to be a BLS transfer, you can still use the CHET line, because our medical control physician contacts the your trauma surgeon here, our trauma surgeon, and directs them to call here. The trauma surgeons talk, and then, like Judy said, if your facility knows it's going BLS, then the trauma surgeons talk, Rady's know the child is coming, and your team initiates your transfer then via BLS, if that's what you choose to do. As the CHET team, we're totally happy to come get any child you want us to.
We had this puzzling admission a couple days ago, and like a quasi-trauma patient, and it met the criteria for trauma activation. It was a high-speed motor vehicle accident rollover. The 5-month-old child was brought in with the mother. The mother had a broken leg, was admitted. So they come in carrying the kid, and so are we supposed to, is this a trauma patient? We don't know. So they took 1 X-ray, and the nurse held him and fed him a bottle. I'm like, is this the trauma patient? I don't know. And then he discharged. But I mean, if that patient had come to your unit, would you have strapped him down and
Were they triaged in the pre-hospital arena as not a patient?
Yeah, he came in as
They gave him through the ED, he had a bracelet on.
So he came in as a patient, but not activated as a trauma.
Wasn't in the car seat.
He was unrestrained,
No, he was
They carried him in, just carried him in.
but in the accident he was restrained. So a restrained rollover is not, by the letter of the law, a trauma activation. You know, it's very black and white, and so, you know, you're already relying on pre-hospital to acknowledge their criteria, but you can always ask, like, was this child properly restrained? Because if they weren't, but yeah, it's,
I guess I thought a rollover high speed was automatic.
now it specifies that they are unrestrained versus restrained. 5-month-old, I mean, you know, properly restrained, I mean,
It was properly restrained.
they must have believed that, yeah.
Well, yeah. Okay, so then if they brought that patient to your hospital,
As an ED patient, it would be an ED patient. It would have been an ED patient. We would have asked, you know, mechanism of injury, speed, restrained, unrestrained.
Work him up, anything, just say, oh, he looks fine.
Probably the same thing. We've done a head to toe, but not as a trauma activation, as an ED patient.
Because we get a lot of, not a lot, but sometimes the parent wants to come, is coming to us, and then we get the child too.
Sure.
It is a challenge to.
So what pre-hospital is supposed to do, you know, they're supposed to make a decision if they meet trauma team activation. They're supposed to go to the nearest pediatric facility. And they're supposed to, unless there's a reason that they have multiple victims and they cannot mobilize that many units. And they have a choice between, you know, dropping off one and then the other, depending on if they're stable or not. So I'm assuming that you're talking about stable children.
Fairly stable, yeah. But
And so,
They didn't take any vital signs or anything.
And it just depends on if they bring them in as actually as a patient or as not a patient, or as a trauma versus an ED. Like your EDs and traumas are split, ours are in one facility, in one space. So it makes it a little bit different. But yeah, I know that that's a dilemma for pre-hospital. We work with pre-hospital a lot. I mean, I do didactic courses with them. They come to the ED for 2 shifts. They go to our OR. We work with them. So those are things that we can always reiterate to them and just kind of support. But their criteria per se are that they, if they identify as a trauma team activation, it would go to a pediatric center for their 14 and under. I mean, it's as black and white as you can try to make it. Yes.
This one, oh sorry, she up front was waiting for. Okay.
Oh, I was just gonna say, even if they just communicated, because we all, adults even don't have a scratch on you based on the mechanism, it would be a trauma, where a child is obviously different. So even if the medics just said, educated us, like, they're coming in as basically kind of an ED patient, they're not a trauma because they were restrained and they don't have a scratch on them and they're fine, you know what I mean?
Right.
They just don't know, so our unknown, like, well, what should we be doing kind of thing?
Because your trauma patient would go here and your ED patient would go there.
Right.
Yeah.
So I don't know if there's a way to maybe help us understand what the criteria is for a trauma activation, if that's written down somewhere. I know the MICN is making that call and the paramedics understand what that is, but we do a lot of times get a stable patient. Well, is this a trauma patient?
Yeah, the county criteria is pretty nice to follow. So yeah, you can get a copy of that. I mean, we have it embedded in one of our policies just so people have access to it. But that's how we manage that, is that it's embedded in one of our policies so that people can reflect on why a pre-hospital would identify someone as a trauma team activation.
For pediatrics.
For pediatrics. Well, no, it's for adults and peds. It's a decision tree that they follow for both.
Okay, I think that's where the confusion is.
Yeah, it's anatomic and physiologic, and then it goes into mechanism of injury, and it talks about the very old, the very young. So it covers everything.
For us, if it's mechanism of injury, vital signs, it's the same. Yeah, so
it's exactly
in our world, this adult world, you look at that, you take that out to a child, and that child gets the full bore.
And the same for pre-hospital. It's identified for both adults and children. They're not separated. It's in the same criteria.
Well, there must be a difference though, because you're saying that since the child was properly restrained and they made that decision, which is fine in the field, but we have adults that are properly restrained and roll over and go through the whole thing. You see what I'm saying? I think that's where our confusion
without evidence, with some anatomic and physiologic.
Yeah, I mean,
That's the EMS judgment call to move it to a higher level of care if they want to. It's the same, I have the whole trauma decision here, but it's the same for pediatrics and adults based on the same criteria, just the vital signs are a little bit different. So you can cover it. I won't.
I can see that, because the mom had
But it's the
always
same
broken
thing,
leg,
and
and
then-
baby didn't have anything, so they just.
So then I guess we need
So
to
it's
make sure we
okay.
get a description from the medics. Is this a trauma patient or is this a
Or just an ER.
And if they're coming into your
eval.
facility, it should be because they're an ER patient. Just unless it's
Well, sometimes we're the first hospital and they just end up coming there,
but
but.
they're supposed to, the whole system is built on them bypassing adult facilities to come to a pediatric system.
I think it's part of it is the adult that's with the child doesn't want to be separate.
Right.
And so what they don't understand is the child's not going to get the best care coming to the trauma area.
Unless they're an ED patient. If they're an ED patient, then they can make the parent request.
Right. But that's the frustrating thing.
Yeah.
Is we're not really pediatric nurses, so then we're going to be dealing with that, and it's frightening for us.
Yeah.
Sure.
So in our system, what we do is we just give feedback. There's a mechanism and a path that you give feedback to pre-hospital, and they can listen to the radio report and they can take in the information, and then you can give them back feedback that that child should have been placed in a pediatric trauma center because they met criteria.
Right, because our thing is we'll take someone for a head CT, a C-spine CT, and you guys don't do that all right away
We
to
don't.
the children,
We
so
do
that's a little bit different.
It is. It's
So
very,
should they have dropped that, should the rig have dropped the baby off in the ED and then come upstairs with the mother? Is that
Yes.
what they should have done?
yes,
Oh, okay.
yes. If they label that child as an ED patient, yes,
And if he wasn't an ED patient, he should have gone to children's.
correct. If he was labeled as
Right, if
trauma.
he was used trauma.
If he was a non-patient, he could be with mom.
So if he was just
A non-patient, yeah.
a non-patient.
Yeah.
That happens too, that's an awkward thing too, because
It is.
you have and maybe they aren't really, but
Nobody to watch
we
the
feel,
Right,
we
right.
feel compelled to do something.
Sure.
That's just hard.
Yeah.
Well, and it's easy to Monday morning quarterback this, but in the moment, of course, like there's a parent who's had a stressful situation. They don't want to be separated from their child, regardless whether it's a trauma patient, ED patient, or non-patient. So the reverse happens to us, where the child is the more injured one, and so the parents want to come. So those of us that are pediatric nurses end up not understanding what to do with adults. So I can feel your pain in a reverse manner, and it's hard though in those emotional moments to tell these parents and family we're separating you because we've designated you differently. So.
I mean, it's a little easier in our facility because they are in an ED, so then you can work with the parent up as an ED patient, and if they rise to the trauma level, then we will transfer them to SHARP. Oh. So we do have that mechanism as well. Mm-hmm. But they're landing in an ED with the patient, so they immediately will become an ED patient as well.
So the transporters just need to be more clear in their communication. This is not a trauma patient.
Yes, and then you need to give them feedback if that happens, so that the MICNs are aware that it's happening.
Will they be confused when we say, is this a trauma patient? Like, yeah, it's in a car accident. I mean, are they going to know what I mean?
Well, a car accident by itself doesn't make them a trauma. It's specific criteria.
But they're already transporting them.
Yeah.
I think the question would be, are you designating this child a trauma patient? Does this patient meet trauma criteria? Okay. Just because I can understand, listening to how this dialogue went and how fast it was happening, like I can hear where some of the confusion is. I'm wondering too, Judy knows the documents or their placements better than I wonder if we send it to your leadership and maybe...
she said she has it back there, yeah.
Yeah, sorry, my husband's a paramedic. He's coming later. He's going to go through all the county protocols, how they determine a trauma, adult versus pediatric, whatever, and we have the trauma decision.
There you go. Okay, well then maybe that will clear up.
So I don't know if
Awesome, yes.
redirect and these questions can be answered later.
Okay.
Right, no, and that will probably be helpful. I like to try and add clarity before we walk away, so
I mean, what you're saying is already here on the trauma protocol decision tree, but I don't want to take away from.
Yeah, you're good. It's nice to know that information's coming. Good.
Yes, I'm not just saying.
Okay. Anything else?
I just want to change gears a little bit. We're so used to receiving patients from other facilities, when they transfer adults from, because of level of care or whatever, they transfer them over to us. We're not used to doing it the other way. What information or what paperwork or what do you need from us when we're transferring a baby to you? Either a basic one or with the CHET? Do you need all the radiology?
So it would be the same things that you're accustomed to receiving. So ideally, we would like an initial, your initial intake. Typically, the physicians have time to do a quick H&P and a transfer note that needs to go with the child. If any images were done here, the read of the images needs to go with the image. And then you typically get your consent to transfer, and we get our consent to transfer. It's pretty streamlined and pretty quick.
And I know one of the questions had been to do studies or not to do studies. And in general, just in the trauma world, the agreement among the facilities, the adult facilities, among each other, and also including Rady Children's, is that as much as possible you hold doing diagnostics for the receiving facility, just because it can be more streamlined in terms of getting done and getting read. And I don't know if you guys are aware of this, but this gets discussed a lot in our M&Ms. If we get a child who has studies done that are associated with the same radiology group, they can view them, they can't write a report on them, because that would be double charging. So it's that silly. I mean, not silly, but it's just that technical. So they can give our trauma surgeons feedback on what the reading is, but they can't write an official report if the sending facility has already written a official report and it's the same group. And they've tried to align their groups in order to be able to see each other's films, which is a great thing, but then it got a little snarly with that part. So And I think someone else mentioned that, we really dialed down the radiation for our kids, and we really avoid doing anything near the thyroid and, some special parts. So it's important, that you recognize that, and the younger children especially, we really dial it down a lot. And our radiology group has been phenomenal over the last, 10 years, dialing it down and making sure that they have an accurate reading and they can see what they need to see with minimizing the radiation all the way as far as they can go. So we work on that really hard, and we have a 64 slicer. We don't have to anesthetize the kids, and so there's a lot of pluses for having their studies done at a facility that we do it a lot. So just something to keep in mind. Yeah.
Right, for sure. And some of those logistics about the reads and the charges are things that I don't think any of us really would know about. But we learn about them.
I mean, we actually got a child recently that had films done at a place where it actually came back as films. And we hesitated to re-radiate this kiddo. We tried really hard to use the black and white films, and we at M&M we decided that wasn't a great idea. But because we're so conscious of trying to minimize how much radiation we expose these kids to. But yeah.
Anything else?
Any other thoughts?
I will say it's easy to give report to the other facility when we call.
Oh, that's nice to hear.
On that.
Oh, well, that's nice to hear.
But I hope you always feel that we're your partners. I mean, using the chat line even to ask a question is perfectly.
Pardon?
We're always glad you guys show up.
Oh, that's well, that's nice to hear.
We'll never push you away. Might have to stay a while.
There was actually, I don't know, maybe 6 months ago, I actually ended up bringing a trauma patient here, and it was really, as the transport nurse brought the trauma to you, and to watch your flow in that, to me, it seems brand new trauma bay was very impressive. I have a great amount of respect for what goes on over here, and I commend you all for your commitment. And it was really neat for me to be able to watch that happen. Thank you. Any other questions for us? Well, thank you again for inviting us to join you. We appreciate it.